Thank you so much for everyone being here. Like was said, I'm Enrique Varela. I actually go by Enrique, and I forgot to put that in the presentation. But like Nikki said, I'm an assistant professor at the University of Utah School of Dentistry, and am really heavily involved with the treating geriatric patients and working with my medical and social work and pharmacy colleagues and nursing colleagues to really build out this age-friendly health systems movement and get it established in dentistry. One thing that was mentioned that I want to talk about really quickly is that I'm the director for the geriatric hospital and special needs pathway, dentistry pathway. And it's such a great opportunity to give dental students some experience in working specifically with older adult patients. And that's really kind of the highest percentage of patients that we see. And typically they have a little bit more medically complex backgrounds than most of our other patients. We're in our third year of our program, and we actually just graduated our first trainee from that program. So I'm pretty excited about that, and hopefully putting some well-educated and prepared dentists out there in the community. But it's interesting because my path to a career that is really heavily focused, as it is now, on the older adult population really started in dental school. And one experience that I remember in particular that kind of served as a little bit of a turning point for me was when I was in my third year of dental school, and I had a 98-year-old female patient assigned to me. And I remember being really nervous about seeing them because I was really afraid that I was going to, do something wrong or hurt this patient in some way. And I was almost completely paralyzed with fear. And suddenly I realized that the way I was behaving as a clinician was keeping me from actually fulfilling my commitment to not only treat every patient the same, but also to provide the best oral health care that I could. And all of a sudden, this fear of not being good enough for that patient in particular, and for all older adult patients, was exactly what was keeping me from giving the care that this patient deserved. And this was really a big aha moment for me because it was the first time that I was really faced with things that I was afraid of as a clinician. So after graduating and practicing for a few years, I actually decided that the only way that I personally would ever be able to completely overcome my fear of treating older adults was to get more training. So I actually applied to what's called a general practice residency, which is essentially a hospital residency program for dentists, where you treat really geriatric patients, you treat medically complex patients, and patients with special healthcare needs. And it just so happened that a large proportion of our patient population were older adults. And one of the biggest lessons that I learned from my time there was that somewhere out there is a really, a patient that's struggling with a lot of healthcare problems, that for one reason or another, they need dental treatment, and that patient is being rejected by most, if not all, the dentists that they're going to. And they need dental treatment. Someone has to provide it to them. I'm trained, so why can't it be me? And really, this is the same kind of attitude that I try to instill in my students. But anyway, as I approached graduation from that residency, I was approached by someone at the University of Utah School of Dentistry about the opportunity to teach full-time. And after weighing all of my options, I decided to take that job at the school because it was a brand new school. And I really felt like I had an opportunity to really have a positive influence on the education of future dentists. And I've been there for about 8 years now. Now, really quickly before I move on, an interesting thing that happened right after I joined the faculty, about a year after I was hired, I was actually selected to be a part of a 5-year HRSA grant that was aimed at developing strategies to overcome systemic barriers to the integration of oral health and geriatric primary care services. And we learned a lot of really interesting things about that. And what was funny about it was that I hadn't really yet decided that that was going to be my that was going to be my focus for the rest of my career. And I haven't looked back, and it's been great. Before I begin the formal topic, I just want to really quickly go over some housekeeping topics. Most of the photos that you see are mine, but some of them have been purchased from an online stock photo website. And I've also made a concerted effort to remove all branding or specific product information to conform with the agreement for this event. I'm also not receiving any financial support by any manufacturers to give this presentation today, so all the information that I'll be presenting to you will be presented in a manner that really reflects the current views of my profession, which is solely based in scientific literature. So, big question, dentistry and dementia, what do they have to do with each other? The way that I'd like to go about answering that question is really by starting with some basics about the mouth and oral disease, and then I'll kind of work my way to the possible connections between oral disease and the brain. But first, I kind of want to go over some statistics with which I think most of us are familiar. Now, recent reports project that the population of 65 and older adults, which is currently at about 54 million, will reach a staggering 94.7 million by the year 2060. Now, what I think this means, at least in part, for both medicine and dentistry, is that we may be facing a potential shortage of doctors and dentists who are properly trained and willing to address the needs of this older adult population. But I think another aspect of this that makes this a little more complicated for the oral health community is that the number of individuals with dental insurance in this age range tends to decrease significantly as they reach their 60s and 70s. And when you combine that with the fact that a lot of older adults live at or below the poverty line, you can see that there's a big problem. There's access problems to oral health care, and having people be able to get that access can become more and more difficult. And as a result, seeking oral health care may become less and less of a priority to these older adult patients, unless there's really kind of an emergent need that arises. Now, current data suggests that dental service utilization rates among 65 and older are currently below 50%. And dental care utilization may only decrease from here because current research suggests that those belonging to racial minority groups such as Black, Hispanic, or Asian are not only becoming the more dominant proportion of the older adult population, but are also half as likely to seek out dental services within a 12-month period when you compare them to their white counterparts. And this is really significant, especially when you consider that oral disease is extremely prevalent in this population. For example, current statistics show that 96% of adults that are 65 and older have had at least one dental caries within their lifetime, while an estimated 20% have had untreated tooth decay. An overwhelming 70% of adults 65 and older currently experience some form of periodontal or gum disease, which really is a big deal. And this is important to my discussion today because research on both the medical and dental sides of the literature base demonstrate that there are various associations between periodontal disease and systemic conditions such as diabetes, hypertension, rheumatoid arthritis, and even Alzheimer's. And data suggests that chronic systemic conditions are a common experience among many older adults. The National Institute on Aging reported that about 85% of older adults report having at least one chronic condition, and 60% report at least two chronic conditions. And the 2015 NHANES study estimates that approximately 70% of adults age 65 and older have hypertension. And the 2020 National Diabetes Statistics Report published by the CDC reveals that about 11.5 million adults 65 and older report being diagnosed with diabetes, while an estimated 3 million probably are going undiagnosed. And these statistics are really important. They have important implications for older adults especially for those who are actually able to obtain routine oral health care, because the more medically complex a patient is, the more likely they are to have treatment interruptions on the dental side due to the complications with disease management. For example, an older adult patient in their 70s with hypertension and type 2 diabetes and a hemoglobin A1C of 9, who is being actively managed by a physician, will probably progress a lot slower through a dental treatment plan than a similarly aged patient with fewer chronic conditions. And this is really because patients with systemic conditions tend to experience more complications in the dental environment than healthier patients. For example, diabetic patients tend to encounter more problems with wound healing and tissue dehiscence following oral or periodontal surgery, and therefore experience longer healing times that lead to prolonged treatment plan completion times. And hypertensive patients, even when they're well controlled, tend to experience spikes in their blood pressure when they visit the dentist. Who knew, right? Dentistry is a very stressful profession. It's a very stressful situation for patients to be in. And if these spikes in blood pressure are severe enough, they can lead to having to postpone surgical treatment until blood pressure is within a manageable level. And this is pretty important, especially for those patients who really can't afford postponing certain types of dental treatment. Now, as a point of reference, what we typically look at when we're looking at blood pressures is that our typical maximum recommended blood pressure for dental procedures, routine dental procedures, is usually about 160 over 100. And for emergency procedures, it's about 180 over 110. And so if a patient goes over those norms, because we use so many local anesthetics that contain epinephrine in them, we typically don't like going any further than those levels, because then they can very quickly get into a situation where they have a hypertensive crisis or something of that nature. But going back to the diabetic patients, the complications can be a little bit more extensive. What the current literature is suggesting right now is that there's actually kind of a bidirectional relationship between diabetes and periodontal disease pathology. Now, what does that mean? Well, it means that diabetes and periodontal disease can actually play off of one another. In other words, poor diabetic control can actually lead to gum disease or periodontal disease worsening. And the literature actually does demonstrate that in certain cases, poor periodontal health or severe periodontal disease can make diabetes a little bit more difficult to control as well. Now, it's estimated that nearly 60% of adults with diabetes also have concomitant severe periodontal disease. And it makes sense when you consider that, chronically high blood glucose levels promote the proliferation of bacterial species that are responsible for periodontal disease. And that the destructive effects of a disease like diabetes on soft tissues can't just be absent from the mouth. It's going to be eliciting those same destructive effects everywhere, and the mouth is no exception. But what makes periodontal disease such a pernicious condition is that the bacteria responsible for the disease can lead to a really over-exaggerated immune response in the host that results in the permanent loss of hard and soft tissues of the mouth, and that forever changes the quality of a patient's life. And it's this disease process that I kind of want to talk about and focus on for a few minutes in order to kind of lay the foundation for the answer to the question, dentistry and dementia, what are the connections? So to start, at the beginning, the mouth is really home to billions of individual microorganisms represented by fungi, mycoplasma, protozoa, and probably over 700 individual bacterial species. And what makes the mouth such a prime habitat for this diverse collection of microorganisms is its relative stability in a few key areas. First, the mouth is able to maintain a relatively stable temperature range, which usually fluctuates between 93 and 97 degrees Fahrenheit. The second thing is that the mouth is able to keep a stable pH environment, which is usually, the range is usually somewhere between 6.2 and 7.6. And third, the mouth really keeps the environment moist through the production of saliva, and the saliva really acts as a carrier for the various nutrients that are required by all these different microorganisms. Now, as complex and diverse as this system sounds, and actually is, all of these different groups of microorganisms somehow find balance. But as with most microbiological systems, this balance is really delicate. And it only takes some minor changes to disrupt this balance and initiate the pathogenesis of disease. Now, a good example of this is the bacterial species that's responsible for tooth decay. It's called Streptococcus mutans. It's a gram-positive facultative anaerobe, which will quickly outnumber other bacteria when even the slightest increase in dietary sugars is introduced into the oral environment. Now, the bacteria can metabolize these sugars for energy, but as a result, the byproducts are more acidic, and it lowers the pH of the oral environment. And that lower pH is what actually leads to tooth decalcification and what we call tooth decay. Now, another example can be seen with some of the bacteria which are responsible for periodontal disease, which can also dominate the oral environment after only a few hours of not brushing your teeth. And to understand the type of damage that periodontal disease can really elicit on the oral environment, I kind of want to refamiliarize you with maybe some anatomy that you're already aware of. So first off, you've probably heard periodontal disease referred to by a couple of different names, such as periodontitis or even gum disease. What you might not know is that the term gum disease is a little misleading, because it kind of implies that the disease and its effects only occur within the gums. And this couldn't be further from the truth. You see, periodontal disease affects a collection of structures, anatomical structures that serve as an important support system that actually keep all the teeth in place. This collection of structures is known as the periodontium. It includes the gums, for sure, but also includes things like the underlying bone, the roots of the teeth, and the ligaments that keep the teeth anchored in their sockets. Now, the gums, which we refer to as gingiva, and I'll probably be throwing that word around a lot, which is where the term gingivitis comes from, are composed of stratified epithelium that's really closely adhered to the collagenous lamina propria. So it's very closely adhered to the bone. Now, as you see in this picture on the right, the gingiva wrap themselves around the bone, the alveolar crest of the bone, and kind of terminate here, and they're closely adhered to the neck of the tooth, right around here. Now, in this picture, what I'll refer to as the anatomical crown of the tooth is right here. It's basically this white part, and the root is right here, this kind of beige part right here. And so this intersection right here between the crown and the root is where a connective tissue or connection of the epithelium actually connects to that area of the tooth. Now, this epithelial attachment is a really critical landmark of gingival health and disease, because like I just mentioned, during good gingival health, the attachment will be right here where we expect it, right around the neck of the tooth, where it will join together to basically form the base of a pocket around each tooth. And this is known as the gingival pocket. Now, when you go to a dentist, he or she will measure the depth of this pocket to evaluate the position of that epithelial attachment. In normal healthy gum tissue, the depth of that attachment is usually around 2 to 3 millimeters at most. But as the periodontium experiences pathological changes, the base of that pocket, and by extension, that epithelial attachment, actually begins to move lower and lower along the root of the tooth. And, you know, as the etiology of this disease continues to go unaddressed, and the primary etiology is the bacteria, but bacteria in a susceptible host. It really kind of ties together with the host response. And that's really where the pathogenesis of this disease starts. But as the etiology of this disease continues to go unaddressed, the signs of the disease will increase in severity, meaning that in gingivitis, you get maybe some bleeding while you're brushing your teeth. Well, that's going to get worse. The attachment is going to start moving lower and lower, and as a result, so is that hard tissue and soft tissue, which means that it's not just disappearing; it's actually being destroyed by several different processes. In essence, the periodontium, remember that we said the gums, the bone, the root, and the ligament attachment is basically being destroyed, and it's failing to do what it was designed to do, which is basically hold the teeth in place. Clinically, what the worsening of this disease turns into is basically even more bleeding of the gums, maybe a foul odor emanating from the mouth, maybe some purulent exudate emanating from the gingiva. And in the most severe cases, the bone will be lost so much that tooth mobility starts to appear, and it becomes so widespread that full mouth extractions are needed, and the patient will need a prosthesis or a denture to regain some level of oral function. And as you might imagine, this can be a very devastating and disruptive event to a patient's life, because no matter how good of a denture I can make, you can get the best dentist out there and have them make the best denture that has ever existed. It will never be as good as what nature put there in the first place. And there can be really some unintended sequelae related to this clinical outcome as well. For example, the complete loss of dentition affects a really important but very little known anatomical arrangement known as the vertical dimension of occlusion, or VDO. Now, the vertical dimension of occlusion, really quickly, is essentially this spatial arrangement that's created by the distance between the upper and the lower jaws when the teeth come together. And that's what gives a face its appearance. That's what allows us to have a patent airway. That's what gives us a lot of the things that we don't really even think about. And throughout an individual's life, barring any oral diseases, that distance usually remains fixed and never really changes, unless you have problems with grinding at night. Then people will grind their teeth down, and then that vertical dimension of occlusion collapses. But this distance is really what forms the basis of everything a person does with their mouth. So how they eat, how they drink, the way they swallow, and the shape of their airway. And when a person loses their teeth as a result of periodontal disease, for example, that dimension collapses and changes the way their mouth functions. They speak differently, they chew differently, their swallowing becomes more cumbersome, and so forth. And some people who lose their teeth will even take on an older appearance than those who that still have their teeth. And this shorter facial appearance tends to affect patients in several very negative ways. Patients will struggle with depression as they deal with the irreversible consequences of losing their teeth. We see patients withdrawing from relationships due to embarrassment over the change in their appearance. Looking in the mirror becomes really hard because it becomes a constant reminder of what they've lost. They begin to self-isolate and engage in less social activities that used to bring them a lot of joy, like going out to lunch with a friend or even being seen in public. Patients will usually also alter their diet to accommodate themselves to their new situation in life. Some end up going toward healthier foods in a renewed effort to preserve the health that remains. Others will continue to eat the same as before, and yet others will seek out newer, softer foods that will replace the joy in foods that they can't really experience to the same degree. And these foods are typically higher in refined carbohydrates and trans fats, and that leads to a lot of different other types of consequences. But even with dentures, patients really become self-conscious and anxious about their dentures falling out while they eat or while they speak. I mean, think about yourself, how you would feel sitting across from a friend at a cafe, eating a piece of cheesecake and having a cup of coffee. And while you're talking, your top denture falls out. And these are the things that patients that experience these types of situations have to consider. These are part of their decision process before they go out. And a lot of people will kind of shy away from ever having to experience that and will become very isolated. In addition to the psychological consequences of losing one's dentition, there can also be very serious physical consequences as well. For example, research suggests that a collapsed VDO, vertical dimension of occlusion, such as in patients who are completely edentulous, can actually complicate bag mask ventilation by disrupting the proper seal. Similarly, studies show that patients who are completely edentulous or have no teeth tend to battle with a more complex form of obstructive sleep apnea. Since the teeth are not present to create a proper space between the upper and lower jaws, maintaining a patent airway becomes much more complicated than normal. This may require higher CPAP settings or bilevel pressure settings to keep that airway open. And as you might guess, higher inspiratory pressures may not necessarily translate into a better night's sleep. It really just kind of depends on the patient. And these complications are just some of the reason why it's so important for us in oral health care to help older adults keep their teeth for as long as possible. With the prevalence of periodontal disease that is being over slightly 70% in this population, it's important that we work together in making oral health care a priority for older adults, right? Making it part of what matters most to them. And that really, I think it really starts out with a basic understanding of what periodontal disease is. So at its core, periodontal disease is an inflammatory condition that's caused by bacteria, with the caveat that the disease pathogenesis can't really occur without a susceptible host. And what this means is that although bacteria form the initial snowball, it's really the host immune response that gets that snowball rolling down the mountain. And as with many other forms of inflammation, it goes through both an acute and a chronic phase. Now, under normal circumstances of good gingival or gum health, some of the oral bacteria will come together to form a really complex collective of colonies on and around the teeth that's known as plaque. You've heard of plaque control in your toothpaste and all that. Well, that's what we're talking about. And the dental plaque is essentially composed of an organic matrix that's made up of food debris, extracellular polymeric substances such as polysaccharides, proteins. It's also made up of nucleic acids, inorganic molecules such as phosphate and calcium, and then the bacteria itself. Now, the bacteria that are the primary inhabitants of this biofilm, at least in the beginning, are mainly Streptococcus and Actinomyces species, specifically Streptococcus sanguis, Streptococcus mitis, Actinomyces viscosus, and Naslundi. Now, this biofilm makes bacteria 1,000 times more resistant to the protective elements of the immune system that float around, destroying their free-floating counterparts. But this biofilm is really, really sensitive to mechanical disturbance. So brushing your teeth actually helps to disrupt the biofilm's maturity. So some of you might be thinking, well, what about antibiotics or other antimicrobial agents? Can't they just put that in a mouthwash and kill off the bacteria? Well, studies have shown that bacteria can actually survive, bacteria in the mouth in these biofilms can actually survive attacks from concentrated antimicrobial agents because of the biofilm, which is why mechanical disruption is really kind of the best option. Now, the biofilm begins to reestablish itself within a few seconds after being disrupted by a toothbrush. So you go in, brush your teeth, and within a few seconds, you start getting some of that organic matrix building up again. Now, as long as the biofilm is routinely disrupted, there are really no appreciable clinical consequences. But once the biofilm is allowed to mature, it can really quickly spiral out of control. And after a few hours of being left undisturbed, the organic matrix begins to be substantial enough to allow gram-positive bacteria to adhere to it. These bacteria adhere to the new matrix and begin expressing new receptors that allow other bacteria to attach in a process that you know as co-aggregation. Now, this reestablishment of the biofilm approximately 2 to 4 hours after the last toothbrushing is what marks the beginning of gingivitis. And this is the acute phase that I talked about. Now, although the bacteria have reestablished themselves at this point, the disease is really still kind of in a subclinical phase. You're not really going to see very many of the disease effects clinically. But as oral hygiene continues to be ignored, the biofilm begins to work its way under the gums. And this is where we start having problems, because you start having an increase in gram-positive cocci, and they start getting deeper and deeper. And this bacterial presentation is really what activates the host's immune response. Now, the first responders, as you might know, are neutrophils and macrophages that reside within the connective tissues. Now, ideally, we would hope that the immune system works the way it's supposed to, right? That the neutrophils and macrophages can eliminate this bacterial infection completely. But as the bacteria multiply and the biofilm remains undisturbed, the neutrophils and macrophages just aren't enough. They quickly become overwhelmed. So the immune system sends in more cells to help take care of the problem. And this is when you begin to see clinical manifestations of the host's immune response to that bacterial infection. The gingiva or the gums will quickly present with erythema, edema, and bleeding on probing. And although the initial lesion has matured to a state where clinical signs are observable, we still remain in an acute phase of gingivitis, and it's still completely reversible. Now, an interesting development at this point is the development of what's called a pseudopocket. And you'll remember that I talked about how when you go to the dentist will measure all the pockets around your teeth. Now, we typically expect those pockets to be around 2 to 3 millimeters at most. Well, what starts to happen during this initial phase of gingivitis is that when you measure these pockets, you'll actually have larger numbers than expected. But it's not because the base of the pocket has started to travel down, it's because the inflammation is making the gums puffy. And so it's making that base of the pocket that stays the same. And then when you're measuring it, the top of the pocket is actually going up and up because it's swelling. And so the numbers get bigger. That's not a true pocket situation, but it's what we call pseudopocketing. But the attachment is that epithelial attachment is still at the neck of the tooth, and nothing has really gone wrong. And we don't necessarily view this as a pathological presentation. Everybody has some form of inflammation around the gums. We can even see it in some calcium channel blockers, patients who use calcium channel blockers and other medications such as Dilantin. They can start to have really puffy gums and still not have periodontal disease. So that's the situation that we call pseudopocketing. But after about 7 to 21 days of this plaque accumulation, and this does happen where people won't brush their teeth for a really long time, the layers of that biofilm start to stack on top of each other. And it starts to make it a perfect environment for secondary colonization by gram-negative species. So overall, the biofilm goes from a really hospitable environment for gram-positive cocci and short rods to one that allows gram-negative anaerobic species to flourish. And a lot of those species that we see are spirochetes and vibrios. Now, the immune system will really increase the presence of neutrophils, macrophages, T cells, B cells, and you'll start seeing a spike in the production of cytokines and immunoglobulins, which will drive that inflammatory process further and further. But clinically, you'll start to see even more edema and more erythema, more bleeding on probing, and the epithelial attachment is still not migrating. Now, despite all of these clinical presentations, what we really use as kind of a landmark for whether or not this is getting worse. We don't only just measure the pocket depth, but we also measure whether there's any bone loss. And as kind of a quick aside, the way that we measure bone loss is by looking at radiographs. Now, as you can see in this picture on the left, the bone here is really kind of at the level of where the really bright enamel and the dentin underneath meet. So right here at this corner here, you can see it right around here. And this is kind of a radiographic finding in healthy patients. In a patient with periodontal disease, you'll see that that bone has actually begun migrating more apical or towards the end of the root. And this is one of the things that we look for, a radiographic finding that helps us to diagnose bone loss, and which is a feature of this disease. Now, as long as we don't see any bone loss, as long as we don't lose any of that bone, we can still reverse the effects of this acute inflammatory process. But the moment that we do lose any bone, the effects become irreversible. Several clinical trials have really aimed at developing strategies for kind of building that bone back and reestablishing that height that's been lost due to the periodontal disease. But the outcomes have been very unsuccessful. The effects of periodontal disease are permanent. And I think it's really important to say at this point that once you get periodontal disease, you'll have it for the rest of your life. Periodontal disease is not curable. And that doesn't mean that the disease can't be managed, but treatment efforts are really focused on removing that primary etiology and helping patients to establish good oral hygiene practices that protect against further bone loss. And that really boils down to establishing consistent practices that disrupt that oral biofilm and getting the patients to adhere to a really good toothbrushing schedule, basically. Now, in this sense, managing periodontal disease is a little like what I might imagine managing HIV is like. Once you contract it, you can't cure HIV, but you can manage the disease to a point where, you know, the patient's viral load and symptomology are practically unobservable. But under the surface, the infection is still there, and it's possibly waiting to rear its ugly head. And that's really what makes periodontal disease such a sinister condition. It's always waiting to flare back up. And we ran into this a lot during the height of the COVID-19 pandemic. Dental offices were not considered essential. And so a lot of dental offices were ordered to remain closed by local health departments. People got behind on their maintenance visits, which are really important to keep the disease at bay. And those periodontal pockets and the connection, the epithelial attachment kept getting deeper and deeper and deeper. And it kept getting deeper for a lot of patients that a regular toothbrush is not going to get down that deep for that patient. So a lot of people experience really major flare-ups of their disease despite doing the best that they could at home. Now, this leads to a lot of bone loss and the migration of epithelial attachment that continues to go deeper and deeper. But when that happens, the biofilm also keeps going deeper and deeper and deeper. And the patient can't really take care of that at home because you need specialized instruments that can actually reach below the gum line. Unfortunately, a fair number of our patients experienced catastrophic flare-ups of the disease and ended up losing all their teeth. And some people might think, okay, so they lost their teeth and now they have to have dentures. What's the big deal? Well, you'll remember that I said that the big deal is that, you know, losing your teeth has a lot of tremendous physical and psychological impact on a patient. I mean, we tend to see, like I said before, increases of depression, isolation, poor nutrition, and it's just very damaging to people. But what about the alternative? I mean, I've seen on TV, can't you get dental implants? And dental implants can hold those dentures in. Well, these patients aren't necessarily good candidates for dental implants because bacteria can still grow on the surface of the implants. And the host immune system will still mount a similar response to the bacterial challenge, which can lead to the same type of inflammatory disease, except instead of being called periodontal disease, we call it peri-implantitis. Now, the alternative for these patients is usually full dentures, which, as I mentioned, can potentially impact an older adult's quality of life in a variety of ways. That, coupled with the fact that the prevalence of periodontal disease is 70% in this population, really make oral health a critical aspect of what may eventually matter most to a lot of patients. Now, there are several different types of periodontal disease, and many of them are modified by systemic factors such as changes in hormone levels during pregnancy for younger adult patients, or the presence of other systemic conditions such as diabetes. Certain patients can also develop more aggressive forms that lead to tissue necrosis. And a lot of these forms of periodontal disease can be relatively easy to diagnose because the patient will come in with presentations like what you see on the screen that are accompanied by a very strong fetid odor that can usually be detected several feet away from the patient. Now, not all periodontal diseases will share the same characteristics like you see on the screen of widespread tissue necrosis and fetid odor. The severity and form of periodontal disease a patient has really kind of depends on certain risk factors. Now, the risk factors for periodontal disease are age, smoking and tobacco use, certain genetic factors, stress, use of certain medications, clenching, grinding your teeth, the presence of certain systemic diseases, and poor nutrition or obesity. Now, you might have noticed that periodontal disease shares some of the same risk factors as some of the systemic diseases that you treat that are common among older adult populations, such as cardiovascular disease. But what could this mean? Does this mean that there's a direct connection between systemic health and oral health? I think there is. Safely, I would say maybe. I mean, if you think about what the mouth is, it's the window to the rest of the body. We ingest our nutrients through the mouth. Everything that goes into our body, barring surgical intervention, goes through the mouth, right? Unless you go the other way. But, what I'm trying to say is that there's definitely a connection between systemic and oral health. We just don't know how to characterize it completely because we've got bits and pieces of the information. The possible explanation could be that these diseases kind of coexist under similar conditions, but the literature base suggests that the relationship between periodontal disease and systemic health really goes a lot deeper. Several studies found that the presence of oral bacteria species like S. mutans and P. gingivalis were actually found in patients with cardiac valves that were being replaced. They actually found it in the cardiac valve samples, meaning that somehow bacteria that are not normally found in those areas, but are normally found in the mouth, are making their way to those areas. And what can that mean for the patient? What that actually means for the patient is that there's bacterial species in a part of their body where it probably shouldn't be in, and that can lead to a lot of different problems. Now, research also suggests that there are really kind of two primary theories. These are the two main kind of thought processes that we're having about how possibly periodontal disease is related to conditions such as Alzheimer's. So the first theory proposes that the host's immune response that's mounted against the challenge of periodontal bacteria produces an overabundance of inflammatory mediators that circulate throughout the body, adding to the systemic inflammatory burden. But additionally, it's also thought that these pro-inflammatory molecules actually cross into the blood-brain barrier and activate microglial cells in the brain, leading to neuronal damage. The second theory really proposes that pathogenic bacteria responsible for periodontal disease actually pass into the brain, either through the bloodstream or via the peripheral nerves. And once they're in the brain, the presence of these bacteria will obviously elicit a host immune response that leads to inflammatory mechanisms within the CNS. And there's some precedent set in the literature for the presence of periodontal bacteria being found in the brains of some Alzheimer's patients after death. Most recently, a study published by Matsushita in 2021 reports that the presence of P. gingivalis in the brains of patients who died from Alzheimer's disease was observed. Siddiqui and colleagues also observed in 2019, they reported in the Journal of Neuroscience or Neuroresearch that they were also able to positively identify through genomic sequencing the presence of periodontal bacteria in the autopsied brains of patients who had died from Alzheimer's disease. Various animal and human models have also established a clear association between P. gingivalis and both beta amyloid peptide and tau proteins. But P. gingivalis, I've said probably about 4 or 5 times in the last few slides. It's not the only bacterial species responsible for periodontal infection. Overall, there are probably about 33 bacterial species that have been positively linked to periodontal disease pathogenesis, and there may be more. These are the ones that we've really kind of discovered up to this point. And although P. gingivalis is not the only bacterial species responsible for periodontal disease, it does seem to be the one with the most sinister connections to diseases such as Alzheimer's. Now, P. gingivalis has been estimated to compose about 86% of the bacteria that inhabits that subgingival biofilm of patients that have periodontal disease. So as that epithelial attachment starts to go lower and lower, and as that bacterial biofilm starts to crawl underneath the gums, 86% of the bacteria that can be found within that biofilm are actually P. gingivalis. Now, P. gingivalis is a non-motile gram-negative rod. It's an obligate anaerobe that can't break down carbohydrates for energy because if you think about it, if its primary location, its primary habitat was deep within the gums, there's probably not going to be a whole lot of carbohydrates to break down. So it breaks down instead amino acids through fermentation for energy. It also needs iron for its continued growth. So if you were to culture this bacteria on blood agar plates, the colonies will eventually turn black after about 10 days because of the accumulation of heme within the colonies. Now, as a gram-negative bacteria, it has both an inner and outer membrane, with the outer membrane providing additional protection against host defenses. Now, that outer membrane is also home to the LPS or lipopolysaccharide, which can actually activate a lot of different elements of the host's immune response, including B cells, monocytes, macrophages, which will lead to the production of various cytokines that really kind of help escalate this inflammatory process. Now, it is currently in the literature, it's hypothesized that P. gingivalis may get into the brain of Alzheimer's patients in one of 2 ways. Either some element of the outer wall of this bacteria is allowing it to make it past the defenses of the blood-brain barrier, or the blood-brain barrier's permeability is actually increasing as a result of the changes that are related to Alzheimer's disease. We just don't know which one of those 2 it is. The answer to the question really is still a topic of investigation. It may be one or the other, or it may be a combination of both, but I think what's important to recognize here is that periodontal disease, periodontal bacteria is really a kind of a dangerous thing that is being found in the brains of brain tissue samples of patients that die with Alzheimer's. And this is really important because if periodontal bacteria really are reaching the brain, as literature suggests, then that suggests that they may be initiating a very pro-inflammatory host response that may very well be contributing to at least some of the cognitive impairment that is being observed in some cases of dementia. I want to be very, very clear that I am not proposing, and that my profession is not proposing, that periodontal disease leads to dementia or Alzheimer's. I think what the literature is really showing us instead is that there's a really strong association between the host's immune response of some individuals to periodontal disease and that there is an association between that and the presence or eventual presence of Alzheimer's disease. But ultimately, what does this mean in practicality? What does this mean for our patients? Well, at baseline and independent of whether or not it has the potential for developing dementia, oral health should be a really significant priority for older adults, especially given the potential for poor oral health to have a very negative influence on overall quality of life. Now, this may be a tall ask for some people because, as I discussed before, older adults are less likely to seek routine dental care due to a lack of benefit coverage or disposable income. And to change this will really require a massive shift in paradigm. And what I mean by that is that for a long time, and even up until now, dentistry has been seen by many people as kind of a luxury. In reality, the current literature base supports a much more robust and meaningful purpose for oral health that is beyond that as what has been historically recognized, particularly as it relates to this process of aging. And it kind of makes sense, right? I mean, when you stop to think about it, patients who don't seek out routine dental care will usually only find themselves in a dental chair under emergency situations. And patients who are routinely struggling with dental emergencies may encounter more problems with chronic mouth pain, poor nutrition, social isolation, or even depression. And in turn, those dental problems might begin to contribute to the worsening of some of the systemic health issues that you're helping to manage. Now, all of these things combine to make good oral health an important aspect of healthy aging. But to help good oral health to become the norm for older adults, we really need to work at changing patients' perceptions of oral health as it relates to dental care. And that really begins by recognizing first that older adults have historically viewed oral health as less critical, and that their access to oral health care is much lower than other age cohorts. Also, as a result of this situation, this population is really prone to much higher rates of oral disease than their counterparts in lower age groups. And also that poor outcomes in the management of oral disease can really complicate the management of some of the more common systemic conditions. So a strategy that has really worked well here at my institution, which is the University of Utah Health, is to make the inclusion of oral health professionals or dentists in those efforts of creating age-friendly health systems a high priority. And the reason for this is because, as we all know, the effects of Alzheimer's disease on an individual really span the entire landscape of an individual's life. And we can really help these patients and caregivers experience overall better outcomes when we work together as a collective. And as a team, we can collaborate on patient care by encouraging patients to seek out services that will keep them healthy in all aspects of their lives, including oral health. So as a rule of thumb, you might want to think about some of the following actions if you suspect a patient may be experiencing some of the initial stages of dementia. And these are kind of as it relates to oral health. First, for those patients that begin to show signs of dementia, it's really important to consider referring them for oral health care as soon as possible so that any major dental problems can be taken care of before the more severe symptoms of dementia develop. And for this, it's really important to develop a close relationship with a reputable dentist in your area. And what I would do is I would actually start by looking around for periodontal specialists who are well rated, establish a really good relationship with them, and then ask them for names of general dentists that they would trust sending your patients to for general dental care. I think one evolution that my profession is currently undergoing is that we're really trying to change the focus from this old notion of dentistry, kind of like going to a barber, being a thing that's only accessible to the few who have money, to one that really emphasizes the need for all to have that access to oral health care that everyone deserves. The mouth is part of the body. I mean, think about how close it actually is to the brain compared to the heart, liver, lungs, and kidneys, the GI system, or any other organ. So it's important that we are careful to not disregard or diminish the importance of keeping the mouth healthy because of all the old notions of what dentistry was, instead of what it's trying to become. Now, a couple of things that you can think about for patients. Usually what we see in the clinic is that these patients tend to have really poor grip strength, or they start losing grip strength progressively. And so what you can start thinking about is looking for products like this. I think there are only two companies, which I will not name, that have these types of products that have large handles for toothbrushes. You want to try to help encourage patients to have as much, be as independent as possible. So really quickly, I know I'm way over my time, but really quickly, if you can't find these large handled toothbrushes, what you can do is just grab yourself a racquetball or a tennis ball, and then poke a hole in it and insert a toothbrush into that. Bicycle handles work really well. Or you can find something similar on online marketplaces that will help the patient kind of retain some independence. Also, using visual aids, putting up signs that say brush teeth at such and such hour, maybe with a picture of somebody brushing their teeth. Asking your dentist to, asking the dentist that you're working with to provide some fluoride supplementation, so they'll make some trays for them and give some fluoride. One word of caution with fluoride is to make sure that you keep it out of the reach of a person, particularly if they're experiencing very severe symptoms, because you can get some toxic effects if you take too much fluoride, ingest too much fluoride. So really quickly, a few key takeaways that I think are important to remember are that periodontal disease is really a very common situation in geriatric populations. And that although the exact nature of the relationship between periodontal disease and dementia is still unclear, there's a definite deleterious relationship that can negatively affect both systemic and oral health. And realistically, as caregivers, being in the planning process for dementia patients, it's good for us to try to encourage them to include oral health care in their list of priorities.